you all. My name is Cindy Carlson. I'd like to welcome you to our meeting for the National Advisory Council for Alzheimer's Research, Care and Services and Risk Reduction. So we're thrilled that everyone's here today. We have a lot of exciting topics to discuss. So as we head into the meeting today, I think you'll see a lot of themes that we've been talking about over many, many years come together. So as we think about moving from research into better clinical therapies, better clinical care, but also the context in which people are living with this disease and their families. So as we set the tone for the meeting, I think you'll see throughout the discussion topics today that we're starting with a discussion about what makes good comprehensive dementia care. So we'll be focusing on that to start with. And again, with good comprehensive dementia care, we're working with people who have the disease, their caregivers, the clinicians, the environment, the whole healthcare systems, community-based systems that we're working with. So we're excited to have that as part of our presentation today. And then we'll be moving into talking some about some of the exciting new research advances that are coming through. So again, we know that there have been 2 medications that have been approved by the FDA through the accelerated pathway, and another one that will be submitted to the FDA. And so as part of that, we know that we were waiting for this for a long time for these medications, and we all have strong feelings about these medications because we want to prevent delayed onset this disease that we're all here for. The other thing is that, again, with these strong feelings, I think we all recognize that all of us are here because we care about Alzheimer's disease. We care about people living with Alzheimer's disease and other forms of dementias. We care about their caregivers, the systems that are here to help support those individuals. So I think as we discuss these topics and talk about these processes, we just want to keep that in mind, that we're all here, we're all on the same page, basically. We're all here for people who are living with these conditions. And so as we've had these discussions, we want to make sure that we're listening to each other, that we're hearing the concerns, but also thinking about how we can take positive steps to move forward. So I think hopefully a lot of us will have feelings about these discussions today, but again, what we aim to do with the presentations today, you'll see after our discussion on healthcare models, we talked about our federal updates, but then also earlier this afternoon, we'll be talking about the decision processes that surround these new medications. So we'll be hearing from the FDA and from the VA and CMS about these processes that we've been hearing about in the news. And again, we really wanted to hear from the leaders that are involved with these processes so that we as an advisory council can better understand what these processes are and what they're not. And so again, some of these processes involve direct patient care and some don't. Some involve coverage decisions, some involve the scientific review of medications. So again, I think that'll be a really informative session for us to learn about these processes and be able to ask questions about these processes. And then we'll lead to our research subcommittee, and that'll be led by Dr. Randy Bateman, our research subcommittee chair. And we'll hear again about the historical perspective of what NAPA has been working on, but then also hear from partners that sometimes we don't hear about in these NAPA meetings. So again, we've invited the 2 companies that have made the medications that have been received FDA approval through the accelerated approval process. So there is another medication, so again, Eisai and Biogen, but then Lilly has a drug that now will be submitted to the FDA for review. So again, that's why these 2 companies were asked to speak, because they have these drugs that have been approved in the accelerated process, but to hear about industry's role and what responsibility and ideas they have to help move these medications into clinical practice. And then we'll also hear from healthcare systems. So what types of changes need to happen within healthcare systems, and share some positive examples. How can we move these drugs from research into healthcare systems? And we've talked at the last meeting when we had our clinical subcommittee featured about how complicated that is to move these things into clinical practice, all the missing links because we haven't had these agents before. And we don't know what the future's going to hold. If things move from IV infusions into subcutaneous injections, that might change the landscape too. So we'll be hearing from a few partners that typically aren't a part of these discussions, so that we can have that information, again, the historical perspective, the role of industry, and then also the healthcare systems role. So I think we'll have a really good discussion today. Again, with these discussions, you know, as a geriatrician who's practiced in memory care for many years, we haven't had new therapies for over 20 years. So we've had pills that we've given to patients. Now they're generic. And so there haven't been as many concerns about conflict of interest. Now there are more concerns about conflict of interest, especially for those of us who are on the advisory council. So we appreciate, we'll be having some public comments later today, asking us to be transparent in our relationships, which we think is completely accurate. We should be transparent. We just want the public to know that we go through a vetting process when we're appointed to the council. They look at all of our financial conflicts of interest and other ties that could be appears conflicts of interest. As physician researchers, a lot of us are very used to putting disclosure slides, talking about that up front, and we will be doing that moving forward with this committee. So we'll be asking our presenters to put disclosure slides up front. We also will be asking all of our council members to submit conflict of interest forms so that those can be publicly available. We're working out that process, but we're in the middle of collecting that information anyway. So for example, for myself, I am a physician investigator. I do work within the VA system and the university, and I am a site lead for a study that is sponsored by both NIH and ASI, called the AHEAD study. So I don't get paid by the drug company, but the NIH ASI collaboration pays for my study team, the study conduct, and all the details of doing those studies. So those types of disclosures will be made available, and if there's any financial gain. So as an investigator, I don't get financial gain, but my team is covered by those funds. So those types of things we think the public should be able to look through and see if that seems like it's skewing our perspective. So there are a lot of other examples, you know, they work in nursing homes or have tests that are developed that we've been a part of, or the drug companies, our stocks, anything like that. So those are things that we will be making publicly available. So just to go through the questions today. So we will have a earlier lunch today because we really want to make sure our discussion on these processes are able to stay together. So we'll be having that early. So some people might like that. But then we will be having our discussion afterwards. So we'll have to make sure we have coffee too, so we don't get our post-lunch sleeping. Afterward, one thing we also want to make people aware of that we will be having, so routinely for NAPA meetings, we have subcommittee meetings that occur regularly. So we have clinical research, our long-term support services, and our risk reduction subcommittees meet separately. Usually those are just at council members. We routinely ask people to present at those meetings so that we as a council can get more information about whatever area we think is pertinent. We will be having a research subcommittee meeting today after this meeting, and we have invited the two representatives from industry today to that research subcommittee meeting, again, to listen, but not to be a part of deliberations or discussions among our council. Because of that, because there is some concern, well, this is an industry, we will be recording that and taking notes so that the public can review that subcommittee. Normally for subcommittee meetings, we don't necessarily make those public, but those this meeting, because we want to make sure we're transparent, will be recorded and notes will be taken. So again, we really hope that today's a good discussion. Again, with all of our strong feelings about the medications, we hope that we can move it into a way that's respectful and a learning situation, and to make sure that we are thinking through how can we move these medications, this new era of diagnostics forward in a way that's helpful for our patient. But how can we hear from other members who aren't necessarily at the table always, our healthcare systems and others? So So with that, I will turn it over to Helen. And we're going to be having the speakers come up here. We're in a different room today, so we're going to be doing a little bit of shuffling. So I think we will be doing a little bit of shuffling.
Welcome everyone. I'm excited to kick off our meeting today with a discussion of comprehensive dementia care with an esteemed panel of colleagues who have been working on this since at least 2019. They held a meeting on this in 2019, and for some of them it goes back much further than that. They recently had a publication in Health Affairs, and they're here today to share what they put in Health Affairs, and then they're also their broader view on these different models. So today we'll hear from Ronnie Snyder from the Hartford Foundation, Dave Rubin from UCLA, Gary Epstein-Lubo from the Education Development Center and also an alumni of this group, and Nora Super from the Long-Term Care Quality Alliance. So Ronnie, I'll turn it over to you.
Thank you, Helen. Really appreciate it. And thank you to the Advisory Council for this opportunity to speak to the full group. We have some slides. I'm not sure who's running those. Okay, let me know when they're up. Oh, there we go.
No, there we go.
There we go. Thank you. Okay, we can go straight to the next slide when you get that up on, I presume, on full show.
Yeah, I'm sorry. Okay. Can you see it at home?
We can see it.
Perfect.
We see the PowerPoint though, as opposed to the slideshow view. It's okay. There we go. Even better. All right, let's go to the next slide, please. We just heard a little bit about conflicts of interest, and we have none. This work that we're talking about is funded by the John A. Hartford Foundation. And let's go to the next slide, please. All right, so before we jump into the content on this particular slide, I do want to let you know, and Helen just referenced this, we actually had a meeting, it was pre-COVID in 2019, late 2019, on dementia care payment. And that was to convene experts to review solutions and describe basically actionable next steps to accelerate the use of, at that time, current and new payment models for comprehensive dementia care. So you can tell we've been working on this for a while. We've got a group of folks who are really passionate and knowledgeable and committed. And so the slide here is really to outline the October 24th, 2022 meeting that we hosted. That meeting came from a conversation that our board had with Liz Fowler of CMMI. And we learned during that conversation that it really could be useful for CMMI to see an outline of what some of the possibilities are. So we then the John A. Hartford Foundation then contracted with EDC, and Nora Super came in to really facilitate lead that work and pull together the meeting itself. And you can see that the purpose of that meeting was to address those practical discussions that are important to payers who are interested in funding comprehensive dementia care models. This is sort of the next step to bringing this reality to fruition. Our objectives included the review of evidence on the things that matter, the quality, cost, and outcomes of scalable payment models, really talking through some of those practical questions that payers have to answer to be able to provide the kind of coverage of comprehensive dementia care models, and then thinking through the recommendations themselves for how payers should address the practical questions. You can see on the right side of this slide the logos of a bunch of the organizations that were included. So CMMI and our foundation, the John A. Hartford Foundation, we brought in EDC and Nora. EDC included Gary, and you can see at the bottom, UCLA is David, and these are the folks you're going to be hearing from today. So next slide, please. This is just a representation of our lead discussants and facilitators. And I mentioned already, Nora, the folks on this top line are those who really led that particular meeting with all of the other speakers included here. So there really was a breadth of individuals talking about different relevant topics that you'll hear about from the various presenters coming next. So if you'll go to the next slide. Okay, this is the Health Affairs Forefront article that Helen referenced. So, we followed up the meeting itself with various communications and meetings, including, for example, we spoke for about an hour with MedPAC in January, and then followed up with this particular written piece that came with the recommendations themselves. We took what we learned at that meeting, we wrote up a piece for Health Affairs, and that piece in and of itself was well received and is a reference now for all of us. So we continue to work with various partners to drive the dementia care payment model development itself. And I'm going to hand it over now to David Rubin, who is going to speak to the next slide, please.
Can you advance the slide? There you go. Thank you very much. Thanks, Ronnie. Back around the same time, this all started getting traction around 2019. Malaz Bastani was his first author of a paper that was also in Health Affairs that outlined the core elements of comprehensive dementia care. It needed first to focus on both the patient and the caregiver. There have been a lot of caregiver interventions that have been tested, and some are quite effective. But comprehensive dementia care includes both the patient, person living with dementia, and caregiver. It includes continuous monitoring and assessment, ongoing care plans, psychosocial interventions aimed at both the person living with dementia and the caregiver, self-management, medication management, treatment of related conditions, and coordination of care. Next slide, please. And at the time of that first meeting, and pretty much still the case, there were 6 models that had been developed of comprehensive dementia care. And these are them, and you can spend some more time afterwards taking a look at the details here, but they differ. They differ on the type of personnel who are administering it. Some of them rely mostly on non-licensed personnel, whereas others actually rely on advanced practice providers, particularly nurse practitioners. Some are based in the community, where others are based in the health system. Some are all telephonic, whereas others have in-face person-to-person. Some have access 24/7, others don't. How they communicate with primary care providers differs. Some are based within the health system and are able to communicate directly through their electronic health records. Order writing, the more intensive programs have order writing by the actual team, whereas the other ones, it's all through the primary care providers. And medication management, most do, but not all. Also, the benefits vary, but the important thing here is that all of them have shown both patient benefit and caregiver benefit. Some have shown benefits on quality of care. I'll show you an example in a moment. The cost of the program is highly variable, and mostly it's because of labor costs. Those that have non-licensed personnel tend to be less expensive, although the caseloads are small there and they are relatively expensive. Whereas those that rely on advanced practice providers tend to be more expensive. The gross savings, these are all very still a work in progress, but some have actually shown to be quite advantageous to Medicare, saving as much as $2,400 a year per beneficiary. Next slide, please. So the first recommendation is that payment model should cover comprehensive dementia care that meets quality outcome measures. You can say that you're doing comprehensive dementia care, but if you don't provide the core elements, and these are examples of quality indicators that are widely used, staging of the dementia, depression screening, annual assessment of cognition, function, and behavioral symptoms, as well as medications, counseling. This is where primary care providers tend to have real problems. Counseling regarding driving, counseling regarding safety, community resources, advanced care planning, and then treatment with behavioral medicines first for psychological and behavioral complications. Next slide, please. These are some data. These are data that Lee Jennings published a few years ago, where she looked at 4 different groups of persons receiving dementia care. First were community-based physicians who had nothing. This is kind of what we're dealing with, the landscape. And the quality indicator pass rate by chart review was 18%, dismal. If you do a quality improvement project, you train them, you have them tinker around with their electronic records, you can kind of get it up to 42%. If you add a general nurse practitioner to the practice, a better 60%. But if you have a specific comprehensive dementia care program, 92%. So this argues favorably for specific dementia care programs that are aimed at Medicare beneficiaries to improve quality, clinical outcomes, and save money. I'm going to turn it over to Gary Epstein-LaValle.
Next slide, please. Thanks, Dave. And thanks, Helen, for the reminder to the group that I am an alumni of the Advisory Council. It's really a privilege to be invited back. And during my time there, this issue of how to pay for comprehensive dementia care was really one of the overarching high priorities for the work of the Advisory Council, and very pleased that we have the chance to present this information again to the Council. I'll be discussing recommendations 2 and 3 from our publication in Health Affairs. Regarding this recommendation 2, the payment model should address both the beneficiary needs and the needs of the person or people caring for the beneficiary as a care partner or caregiver. The beneficiary and the caregiver should be assessed at enrollment into the payment model, and both should be reassessed at least annually and after major events such as hospitalization of the beneficiary or an event in the life of the caregiver, which would add significant stress to the caregiver or reduce availability for providing caregiver support. It's important to assess caregivers because it's known that they're at increased risk for adverse health effects, and impaired caregiver health not only directly impacts the caregiver herself or himself, but the social support system surrounding the beneficiary related to dementia care. To implement supports for caregivers through the payment model, it's recommended that community-based organizations should be integrated into services delivery. These community-based organizations are important providers of services for persons living with dementia, including education about living well with dementia and relying on external supports when needed, such as adult day programs. And the community-based organizations are also needed to provide essential services to caregivers, such as education, support groups, and individual counseling. The next slide, please. This recommendation may seem straightforward, but it has complexity. To be eligible for the payment model, the beneficiary must have a diagnosis of dementia. There is an urgent need to address underdiagnosis or lack of timeliness regarding diagnosis. We are recommending that a strong initial diagnostic workup occur prior to entry into the model. Then, during the process of enrollment, the model should include a confirmation of diagnosis. This is crucial for distinguishing between mild cognitive impairment and dementia for several reasons. Regarding treatment decisions, beneficiaries with mild cognitive impairment may be eligible for new disease-modifying treatments for which those with moderate dementia may not be eligible. Also, for overall cost of delivering the alternative payment model for dementia, the exclusion of the large pre-dementia population is important for containing costs of the overall program. And finally, a diagnostic confirmation at entry is important for planning the initial care services. We are recommending that the costs for confirmation of diagnosis should be under the primary benefit and external to the costs covered by the alternative payment model. And regarding dementia stage and symptom severity, we are recommending pathways within the model which have different levels of service intensity. The choice of pathway regarding level of intensity should be guided by disease severity and associated symptoms being experienced by the beneficiary. a recent history of use of high-cost services and the strengths or weaknesses of the caregiving resources. And the process for determining pathway within the model should result in delivery of lower cost interventions for beneficiaries with less symptom severity and higher cost services to those with greater clinical needs. We've been asked about palliative care, and this should be available to beneficiaries when indicated. And finally, regarding exclusion from the alternative payment model, it should not include those who are already enrolled in program for all-inclusive care of the elderly, PACE, beneficiaries already in residential care, or beneficiaries enrolled in hospice. And next slide, please, and over to you, Nora.
Great. Thank you, Gary, and thank you to the council for having us today. We are excited to continue to collaborate with you all on moving these comprehensive dementia care models forward. Our recommendation number 4 focuses on health equity issues. We recommend that comprehensive dementia care programs should be widely available to Medicare beneficiaries, especially those living in rural and underserved communities who have traditionally had difficulty accessing healthcare systems. Research shows that this is consistent, of course, with HHS emphasis on health equity, and we focused on how to reduce health disparities in scaling comprehensive dementia care models. Because many of the models are now being implemented within academic medical centers, we explored ways to ensure that those living in underserved communities do not suffer further inequities. Research shows that racial and ethnic minorities are less likely to receive timely diagnosis, receive comprehensive evaluation, and determinants of diagnosis are often multifaceted. We recommend that CMS provide incentives for small community healthcare providers and rural practices to participate, and payments could be adjusted based on the social determinants of health of the population served. We also recommend that model participants should contract or partner with trusted community-based organizations. Next slide, please. Recommendation 5 focuses on the form of payment, and we're recommending that it should be capitated based on the severity of symptoms and available resources. Many of those involved in our discussions and research that we've studied conclude that existing codes are insufficient to provide the level of services necessary to deliver comprehensive dementia care, particularly for services that do not fit into the traditional fee-for-service structure, such as care coordination, adult day health and respite, and caregiver interventions. Capitation provides the most flexibility for providers and assures CMS can meet budget requirements. And as we've stated, such an important element of these comprehensive dementia care programs is that supportive family caregiver services should be included and should be paid for out of the capitated amount. One last thought is we also saw that these models that we studied are within traditional Medicare payment systems, but strongly believe that Medicare Advantage and special need plans should be encouraged to provide comprehensive dementia care, and that we believe they currently have the flexibility under value-based insurance design model and the special supplemental benefits for chronically ill. But CMS could put out guidance that clarifies that dementia care programs are allowable or provide higher rebates for comprehensive dementia care. Next slide, please. This slide shows the beneficiary pathway selection that we're recommending. Insufficient caregiver availability and resources, or a mismatch between caregiver resources and dementia severity, place beneficiaries at risk of high cost and poor outcome care. These beneficiaries should receive all elements of comprehensive dementia care plus enhancements, which may include additional services and more frequent follow-up. In discussions with the CMS Innovation Center, it was noted that every alternative payment model tested by CMMI has to have a strong thesis for savings. In their initial white paper and new cost data released a few days before the October convening, the Alzheimer's Association recommended creating 3 pathways for determining payment. They estimated that about 45% of beneficiaries in the new model would be in the mild or moderate stage of the disease, 24% would be in pathway 2, and pathway 3 would be for those in the severe stages of the disease who also have inadequate caregiver supports. To reduce complexity, we also recommend 3 pathways for payment. Over time, we expect that the new dementia care model would reduce the share of beneficiaries needing more advanced support. Next slide, please. This lists our 5 recommendations, which we go into in more detail in the health affairs paper that was mentioned in the beginning. Next slide, please. We also want to acknowledge that on April 18th, we were delighted to see that President Biden issued an executive order to support care workers and family caregivers. And among the more than 50 directives, he called for consideration of testing a new dementia care model that will include support for respite care, as well as many other provisions that would help all caregivers, but especially those caring for people living with dementia. This executive order builds upon the Bipartisan Comprehensive Care for Alzheimer's Act that was reintroduced in the Senate and House this March. This legislation asks CMMI to test a different payment structure for dementia care management. We strongly encourage the Advisory Council to endorse a new dementia care payment model so that we can move forward quickly to implement. As you know, millions of Americans are living with dementia today, so it is critical that we act as soon as possible to improve their care. Next slide, please. Finally, we wanted to make you all aware of another important development. CMS is considering a geriatric surgical measure and a geriatric hospital measure. Both proposed measures include domains focused on dementia and delirium. We strongly support these measures, which align with our overall recommendations. We hope that you as council members or individuals will submit comments in favor of adopting these measures, which are due on June 9th. Next slide, please. This slide shows our contact information. We're happy to take questions now or via email after the meeting. Thank you very much.
Thank you all so much for that presentation. That was very informative. Each of you here, and for the whole group for contributing to that. I think
That's weird.
time for council members for questions. You have about 5 minutes of questions from council.
So the sound will pick up.
You can hear us okay?
Stop
Can you hear
sharing.
me okay?
No question.
You know, as
Okay. Stop
Nora,
sharing.
Nora Super, can you hear
We can hear fine. There's a little bit of background noise. I think someone might have their mic on. That's
they're all
all of your mics are on. Okay, go ahead. We're good.
Thank you for sharing the comprehensive models. I'm familiar with most of them and the article. That was very helpful. So I actually have 2 questions. My first question is, since many people with dementia, more than 50% of them have 5 or more chronic conditions, how do we deal with the whole person in these models? I can see the heavy emphasis on the expertise in care for the dementia diagnosis, which is very important. But because they also have the diabetes, the heart disease, and the multiple other things and medications, is it assumed that that's collaborated with the PCP or actually managing those also? If you can answer that first one.
Can I add on to that too? And related to that, when you consider the severity of the dementia as the choice of which level they get, do you consider the severity of the other chronic conditions, which may be more severe and having more of an impact on their health and well-being?
We'll let the doctors answer that one.
Yeah, I'd be glad to take a crack at that. So first of all, in that slide I showed on comprehensive dementia care, yes, treatment of comorbidities is part of this. Now, the question is when it becomes the jurisdiction of the primary care provider and when it's the jurisdiction of the dementia care specialist. It really varies. It falls a primary care problem or is it a complication of dementia? And so a lot of these are worked out on a local level, but in fact, co-management of chronic conditions is truly part of this. And so the second thing in terms of the payment model, details are really being worked out there. whether in fact comorbidity adds to the which tier you're in. The original tier, since it's a dementia care model, was really based on behavioral and psychological complications. But you could imagine that comorbidity might also enter into that. And that's a really good thought to bring up if CMMI is listening.
I would add to that that the index events, hospitalization of the beneficiary or the caregiver, those are not dementia-specific index events. Those can be medical events, especially in the life of the caregiver. So excellent questions. And of course, that flexibility needs to be accommodated in the model.
And so I live in Georgia, and we recently have funded dementia care specialists per se, one person for AAA. And when I look at what your model shows, the closest it would be the Benjamin Rose Institute, but I'm not even sure if it meets that. What would you advise states that are going toward bringing this funding in, and how that person should be interfaced, trained, and working when you're talking about that level of staff?
So, ironically enough, the American Geriatric Society meeting was this past week, and Steve Council from Indiana presented on a program they have in Indiana where each of the counties has a dementia care.
You turn that off.
These are, it's mostly a social model. And so in a sense, it would really need to be tweaked to be comprehensive dementia care, because the comprehensive dementia care has to be integrated within the health system to co-manage other diseases and coordinate care. So those are still a work in progress. He showed some very good preliminary results of quality, but integrating caregiver care and care in the social system with the healthcare system is going to be very important.
And I would just mention that the last model that we've listed that is named Integrated Memory Care Clinic is actually based at Emory and is active in Georgia and coordinating with the AAAs as this has been being implemented. So we know that Dr. Carolyn Clevenger is listening today and is the lead of that. And I'm sure happy to give you more information about what's going on, as we know Georgia is being very thoughtful as they move forward in many other states as well, looking at ways to really bring in the social care aspect. But as we said, to be comprehensive, we believe it needs to be integrated with the medical care.
Thank you very much. I'm very familiar with Emory's program. They're outstanding. Is wait.
Thank you. And our last question for this session, Dr. White. Thank you. And I have to admit, it's probably not a question, but more thanks and commentary for the group. First of all, thank you for the presentation, the background on the recommendations. As all of you know, and have been working with the Alzheimer's Association on this issue probably since about 2018. This is close to one of our priority objectives around comprehensive care for Alzheimer's. One of the things that I think would be good for all of you to know is that this is one of those issues that has bipartisan support currently right now, and even last year before finishing the session. Last year we had 134 in the House and 39 in the Senate supporting comprehensive care for Alzheimer's and an alternative payment model on this. Right now, with the reintroduction, we have 17 in the House and 14 in the Senate. So again, thank you for the recommendations, the support on this issue, and certainly we're seeing a lot of bipartisan support for making sure that we're caring for those with Alzheimer's and other dementia in a comprehensive way. All right, so I think we'll go ahead. Thank you so much for those presentations and the information and for the comments and response to comments. So we're going to go ahead and listen to our federal updates, and I'll turn it over to Helen.
All right, thank you, everyone. So, folks in the room, apologies for the technology. We're working on it. So Thank you for your flexibility. We are going to now turn to our federal agency updates, and we don't have as many as usual today, which is good because we're going to have our presenters come sit up here in the front. So we are going to go alphabetically: ASPE, CDC, IHS, and NIH. So I invite Lisa and Aaron and Richard to come up to. Oh, no, I'm sorry, not Aaron. Lisa and Richard to come up to the front with Tifa, and we'll just everyone hold a minute. We'll shuffle it. Hopefully we can advance the ghost slides that are not even connected.
What? Camera wants to. Camera wants to.
I kick us off. Sure. All right. Hi, everybody. My name is Barry. I'm the Deputy Assistant Secretary for the Office of Behavioral Health, Disability, and Youth Policy within ASPE, the Office of the Assistant Secretary for Planning and Evaluation. And so it is my pleasure and privilege to provide ASPE's update today. Our update is actually a little bit less of an ASPE specific update, but rather more of an update on activities within HHS related to the recent historic announcement by the Biden-Harris administration related to the executive order on the care economy. So that has been one of the most significant updates and actions taken by the administration in this space, very, very relevant to Alzheimer's disease and related dementia. And so that's what I'm going to provide a little bit of an update on today. So a little bit of background. I think everybody in this room, understands why this executive order is so important. High quality long-term care is critical, but a majority of families in the U.S. can't access the care that can. Demand for long-term care is large. It's projected to grow even further with the aging of the population. And we know that high quality care is labor intensive and it requires a rigorous workforce, particularly the cases related dementia, which are often characterized by the need for care. And so for the people through this advisory council who we really seek to serve, this is a critical impression. But right now, many families who are affected by who have an older member of their family who have care needs or members of their families who have disability-informed surgery simply can't access the care that they need. Or when it's available, they have tremendous difficulties in affording it. And of course, we just before this is a shortage of long-term care workers. One reason for this is really important and valuable as these jobs are. We know that long-term caregivers are often underpaid. They often do not have access to benefits, such as retirement benefits or health insurance. And also, many of the jobs as currently set up provide limited opportunities for career advancement. This creates a lot of challenges both in recruiting workers and also retaining them. And so high rates of turnover are also a key challenge in this work. Now, also, in addition to the paid workforce, we know that the unpaid family caregiver workforce is also a critical source of care and support for older adults with disabilities more broadly. But also this workforce needs a lot of support. Caring for a family member with a disability or with Alzheimer's disease is an incredibly rewarding and meaningful experience, but can also be challenging. And the family members who take this on deserve our support as well. With all that in mind, and to expand and also accelerate our efforts to meet the critical and pressing needs of supporting the care economy, on April 18th, President Biden signed the executive order on increasing access to high quality care and supporting caregivers, which is truly historic and the most comprehensive set of actions ever undertaken by the executive branch to address this pressing national challenge. It includes over 50 directives. The directives are related to both long-term care and child care. But to highlight a few kind of key elements in the long-term space that are particularly important to the populations that we focus on as part of our advisory council. We include several actions to improve job quality. For example, it directs federal agencies to identify opportunities to improve care workers' access to health insurance and benefits. And it focuses on improving working conditions, for example, specifically in the nursing home context, by reiterating our commitment to establishing minimum staffing standards in nursing homes, which are not only of benefit to residents, of course, but are also critical to the quality and the experience of the workers who are in these. It also includes provisions to improve access to home and community-based services. This is one area where we have already seen really historic policy announcements by the Center for Medicare and Medicaid Services through the recent proposed rulemaking just within the past couple of weeks on ensuring access to Medicaid services, which includes a suite of really exciting policy proposals to expand HCBS, including a new quality strategy, and also actions that are specifically targeted at improving wages for workers who provide HCBS. There are also, the executive order also includes actions to support family caregivers. These include encouraging the integration of family caregivers into the healthcare setting, and also very relevant to the updates that our recent presenters provided, directs HHS to consider testing a new CMMI model on dementia care that includes, importantly, family caregiver support such as respite. There are also notable actions to support the caregiving needs of our veterans, including expanding the VA's home-based primary care program, and also expanding the veteran-directed care program for veteran home health services to better empower our veterans to make their choices about the settings in which they would like to receive. And then finally, a particular excitement to AFSCME because of our role in research and data, we can't measure our progress or hold ourselves accountable unless we have more data on the long-term care workforce, and in particular on the workforce providing home and community-based services, which has long been a real gap and a challenge. And so excitingly, the executive order also directs HHS to work in partnership with the Department of Labor to identify opportunities to expand and improve data on our HCBS workforce, which can allow us to continue to build upon and inform our efforts going forward. So I'll say that we at HHS are tremendously excited to work with our partners, both across the department, but also across the federal government and our external partners who are key in this effort to implement all of these historic and very important provisions to support our care.
Thank you. So good morning, my name is Lisa McGuire. I'm from the Centers for Disease Control and Prevention, and I'm going to provide an update of what's been going on in Atlanta. So next slide, please. First thing I want to share with you is an exciting publication that really is talking about promoting healthy aging to reduce the risk of dementia. So this was included in the special issue of Generations that was released for Older Americans Month. It was a partnership article between the Alzheimer's Association, Us Against Alzheimer's, and really kind of showcases some of the work that happened through this council through Goal 6. So I encourage you to check it out. Next slide, please. I want to share with you another recent publication from CDC. This was an MMWR, or Morbidity Mortality Weekly Report that was published in March of this year. And this report was looking at self-reported memory, so the number of people who've indicated that memory has gotten worse in the past year, who are age 45 and older. We call that SCD. So we know that about 10% of older adults say their memory has gotten worse in the past year. We know the prevalence of SCD tends to decrease with increasing educational attainment. And the parts that I want you to look at in this paper, one I think is very important for this council, is this last bullet on this page. Less than half of people who say their memory's gotten worse in the past year have actually raised or talked about those concerns with their healthcare provider. Next slide. And that's also a Healthy People 2030 objective. One of the biggest findings from this article was looking at the race and ethnic differences between for SVD. And you can see that the lowest group was the Asian group, and the highest group was American Indian Alaskan Native. So there's lots of work for all of us to do on this council to help people reduce their risk, also focusing on social determinants of health. And we have in the side there on this graphic, which is free and downloadable, you can see some of the suggestions that public health makes. Next slide, please. We are so excited that next week in Atlanta, we're going to be holding the first Dementia Risk Reduction Summit. If you have not registered, there are a couple seats available. If you want to make the trek to Atlanta, Atlanta's beautiful this time of year. But this is going to be a very, very exciting summit with a lot of national attention on it as well. If you cannot make it to Atlanta, my little secret for you all today is later this week, we're going to be announcing a live stream option. But I know that Dr. Tisa Marie Sherry will be there to help kick us off, as well as Joanne Pike and some CDC leadership as well too. So next slide. We recently completed our second cohort of BOLD public health programs. So this is the funding that helps build that BOLD infrastructure to states, political subdivisions of states, tribes, and tribal organizations. So the first cohort of BOLD recipients was a 3-year award. And so the second cohort will be a 5-year award. You can see here the way that it's going to be broken up. There's going to be a component 1, component 2. Component 1 really will be more that planning phase for BOLD awardees to establish a state plan, get their coalitions together. And then the component 2 will really be focusing on implementation, or that phase 2. Next slide. So the applications have closed. We received 53 applications. A nice mix of component 1, component 2. We received states, cities, counties, and some tribal organizations. So we've conducted the initial review process. We're looking at the results, and I will be able to hopefully share with you at the next meeting who the second cohort of BOLD program awardees will be. Next slide, please. Other exciting news going on, that public health roadmap is being updated. It's being updated as we speak. The content is being reviewed by CDC. There's been over 100 individuals, that many in this room who participated in work groups, either reviewed drafts of the material or served as consultants throughout the process. So we definitely thank your time and appreciate the work. And I think many people are going to be very excited to see how this new version is laid out. It's going to be, I think, there's fewer objectives, very clear outcomes from the specific objectives moving forward. Next slide, please. So once we release that state and local public health roadmaps, we're going to start revising the roadmap for Indian country. So if you're interested in participating in that process or keeping up to date on that process, there's a QR code on the screen. Or an interest form link that you can fill out. And this will also be available in the slide set that is sent out for the public as well. Next slide. CDC, one of the things that we're also doing through BOLD is making sure we're doing timely analysis and reporting of our data. We have 2 modules on the behavioral risk factor surveillance. We have one on subjective cognitive decline, and we have one on caregiving. So the latest state-based infographics have been released. They're available on our website. So for any year that your state administers the BRFSS, we do have a state-based infographic already completed on your website, free, downloadable, anyway, you can add logos and those types of things as well. Next slide. This is a really interesting project that the Alzheimer's Association is doing with CDC. is because data is extremely important. We just heard Dr. Sherry talk about data and being able to have data to measure our outcomes and our impact. And so one of the projects that we're collaborating on with the Alzheimer's Association is really trying to get training to states and public health departments so they can understand data, understand what they can do with their data, what stories they can tell with that data, and how they can use that to truly argue or work towards some impact and change. So this is the first cohort of our Data for Action scholars. You can see the recipients: Arkansas, Connecticut, Illinois, and New Jersey. And so this is something that we are anticipating doing in the future, and we'll have more to share from cohort 1 and the later cohorts as we're recruiting. Next slide, please. Always want to point out we have a Healthy Brain Resource Center. So this is a one-stop shop for free downloadable resources that are available. Currently, there's 150 on there. They're all free, and they've all been vetted for their validity as well too. If you're interested in having things added to it, there's a link that you can't see with this black bar in the room, but there's a link, and you can request to have your information included. Next slide, please. And I wanted to share some partner resources. So one of our partners, IA Square, International Association for Indigenous Aging, has developed some really neat materials that are culturally aware on the warning signs of dementia. And also they have a series of RAC cards related to healthy eating and brain health. So those are on their websites. Once again, free, downloadable. And some of them have different optional layouts, so you can select which ones you're most interested in. Next slide. And that is it for me and CDC. Thank you all very much, and we'll turn it over to Dr. Fate.
Hello, I'm Bruce Sink with the Immediate Health Service, and I'm going to speak on behalf of the small team at IHS in the elder care team that's implementing funding, relatively recent funding, for the Alzheimer's grant program. And I hope you'll see that this is a group of folks working really hard. The advisory council and the NAPA work has all along winded our back in addressing Alzheimer's through IHS, and more so in the last few years. So on to the next slide, please. This is just an overview of the kind of the general approach to the work, and you've seen this before. Most of the resources we intend to get out directly to tribes, tribal organizations, urban Indian organizations, and the federal service units, federally direct services that work in partnership with tribes to address Alzheimer's. There's smaller components that support that, the biggest of which is education and training to build capacity in what is essentially a primary healthcare system in Indian country to address dementia, and then work in outreach, dementia awareness, and the infrastructure around program support and data. Our funding levels, we were funded for the first time in 2021. We've been fortunate to be funded by Congress in 2022 and 2023. And now we have some resources and that we can make a commitment to get these resources out. And the initial work was started with 1 year's funding and a lot of hope. And now we have resources to go with that. So we'll move on to the next slide. As I said, the bulk of this funding goes out to the tribes, tribal organizations, urban Indian organizations, and federal side to address Alzheimer's directly, in particular to support models of care that are evidence-informed, but that draw on the resources of the communities to build models that work for those communities. We have 4 awardees now entering their second year of funding, and just recently we were able to bring them together with the ACL API grantees, tribal grantees, at an ACL funded meeting, so that we could bring both the Indian Health Service grantees and the ACL funded tribal grantees together and begin to cross-fertilize and share, so that it's not just a small group, but a bigger group. And we hope we saw already that they start to see themselves as part of something bigger. But the exciting news is that we now have funding opportunities out on the street again for a second year of funding, announced March 29th for again on the tribal side, as well as program awards for the federal side. That was announced April 6th, and we hope we'll be funding those by the end of the year. Because our funding has continued over these last few years, and actually we had a small increase in 22 and 23, we're actually able to increase the amount of funding available for these awards this year. So we'll be excited, I hope, by the next time we meet to be able to tell you more about, the applicants and maybe even the awardees. So, next slide. This is just the detail about those awards that's more for reference. I will say that on the federal side, we've expanded a little bit the flexibility to include some really targeted programs that we hope service units will use to address caregiver support and case care management services through the federal program. The next slide. We have entered into we've really built on a partnership with the Northwest Portland Area Indian Health Board, and we'll be initiating 2 new ECHO series. Over the last year, the Indian Country ECHO program at Northwest Portland Area Indian Health Board has, with their own funding and with just some in-kind support from us, had a small ECHO series. We're building on that to do something a little more intensive with 2 specific series. One series is a clinical ECHO focused on primary care workforce, and again, across Indian Country, with a focus on detection, diagnosis, management of dementia, and a curriculum that will sort of take folks through all of the key elements. And we hope to build an active, engaged learning community, folks presenting cases and learning from each other. The second ECHO, and these will take place, each ECHO is once a month, so every other week we'll have an ECHO. But the second series is caregiver support focus. So we learned through our work, and you've heard about this in previous years, where we adapted the REACH intervention at the VA to Indian Country. We learned that we have workforce in Indian Country through our public health nurses, through our community health representatives, and more broadly, actually, beyond the health system in the aging network, that are in folks' homes, that are available and often giving support in an informal way to caregivers. This ECHO is designed to build some structure and mentorship around that support, so that folks have a place to go to share with each other and to ask questions, so the cases for this ECHO will be cases like, this is a problem a caregiver and their care partner brought to me, and I'm not quite sure how best to handle it. How would you handle it? And to gain that kind of confidence as they move out into the homes to support our caregivers. So that the clinical ECHO starts on May 11th, and the caregiver ECHO starts on June 22nd. And the other thing I'd like to point out is that the director of the caregiver support program actually comes from a bold awardee from the CDC. So again, we're really working hard to sort of make sure we leverage resources, all the federal resources that come into Indian Country, and make sure that even if they come in from different streams, we're helping folks pull those pieces together to do the most they can. The next slide, please. We've talked before about the Indian Health Geriatric Scholars Pilot Program, adapted from the VA's really highly successful VA Geriatric Scholars Program, with a very similar focus, which is building capacity within primary care. And we've been so excited, so delighted with the results so far. We currently have 50, in the first cohort, we have 15 scholars coming from 10 HHS tribal and urban programs. They've been through their intensive training. They're now working on local improvement work. They're sort of taking their training and applying it locally. The projects they're involved in are range from dementia detection and diagnosis, 9 of those projects, 3 projects around medication management, medication review, and improvement, and then 1 focusing on falls, particularly falls and folks living with dementia. So that's the kind of work that they're doing, that they're applying locally, and I get to work with them, and it's so exciting to see the work they're doing, and you know, it's super. I mean, this is like their time, right? This is their full-time clinician who are committed to improving care for the elderly, and they're doing this as part of that work, and it's really just incredible to see that. We're expecting a second cohort this year. The first cohort were made up of physicians and PPAs and pharmacists, and we're looking at whether we can expand into other service lines this second cohort. There's one other story I want to tell you about the geriatric scholars. Last month, the National Pharmacy and Therapeutics Committee, which is a standing committee at IHS that addresses pharmacy and therapeutics, gives advice, develops a core formulary of medications to be available in all federal sites, was addressing medications related to the elderly, and then, you know, so, and at these committee members, you know, present really comprehensive overviews of the conditions that are being addressed and the medications available, including pharmacoeconomics, and just a really detailed presentation. The presentations on the Alzheimer topic was one of our geriatric scholars, who was selected because she had indicated an interest in Alzheimer's. So that's really what we hope to build is through the Geriatric Scholars Program, is folks who locally are working to improve care and then become resources nationally to improve care for folks living with Alzheimer's and caregivers. The other couple of projects that I've mentioned before, just to update you, we're in, I think, the 5th or 6th months of a early detection initiative around oral health with 5 IHS tribal programs working to integrate early detection strategies into oral health care, into dental care. And the motivation here is we're not asking them to take on the load of detection of dementia for the system. What we're asking them to do and to think about, and that the challenge they've taken on is to see how having in their toolkit tools to help them identify folks living with cognitive impairment will help them provide better oral health care. And if they've identified someone with cognitive impairment, to know the pathways and have the pathways in place, both pathways towards diagnosis, but also pathways to the community to get support. And in the last meeting, actually, folks from the Alzheimer's Association from EDL and Allison from the services delivery side came and presented as well and helped us with those sessions. Really appreciated the Alzheimer's Association support. And finally, the Geriatric ED Accreditation Initiative. I'm excited to say at this point, it says 8 IHS and tribal EDs are accredited. As of now, all 9 are accredited as the basic accreditation is geriatric EDs. This is actually an initiative led by our nursing program, and we've been in support of that. But again, building more competency in geriatrics and care for folks living with Alzheimer's in this mix of tribal and IHS emergency departments. The next slide. So that's where we are, and I'm looking forward to in 3 months being able to tell you what's happened next. Thank you.
Thank you. Richard Hodis, Director of the National Institute on Aging. He had a report on progress through NIH. And a lot of this material will provide overviews which are intended to accompany a lot of links to some things going on, which I hope to take advantage of. We move to the next slide. Spending updates. Next. This is an overview. Maybe everyone on this committee should take a look and take great pride in what's been accomplished through the Act and through this committee. If I just ask you to pay attention first to that first line, which is the sum of Alzheimer's and related dementia research. This is spending at NIH, and you can see in 2015, little over $600 million was increased in FY22 to $3.5 billion. And that's a 5.6-fold increase. The other numbers indicate that this is driven by scientific opportunity, not formula, applied to related dementias in each of these subcategories. So it's a huge increase in appropriations, which has allowed us to do some of the things we have and reflects the past and continuing support by Congress. I just mentioned as an aside, last week was the Senate appropriation hearing. And if any of you, those of you who didn't have a chance to review it, it is archived. And it was quite remarkable to me to see the continued support by multiple speakers, multiple members who both applaud the progress that's occurred and spoke in favor of continued and expanded research support. So thank you for the committee, which I think has been responsible for a lot of that. Next slide, please. I just noticed when we look at the workforce, the researchers being recruited into the field, that through 2015 through 2022, the time of this committee in charge, really, a third of the funded investigators each year over all these years turn out to be new and early stage investigators. And about a fifth, or the category we defined as new to the field, that's people who've never even applied for research in this area. So not only are we continuing to fund the growing and talented body of investigators in the field, but we're recruiting new scientists, new perspectives into research. Next, please. And next. Just wanted to include this description here in the context we've been focusing on today and in the past about data and the importance of it. This is an initiative that has been solicited in a request for proposals that will be due in the summer. If there are any that are received and are adequate in terms of excellence, peer review, could be funded by early 2024. It's a real-world data platform that intends to bring together data from multiple sources. There's electronic health records from providers, CMS, and other administrative records, pharmacy, eventually to such things as wearables and through geopositioning, other determinants of risk, all in a formulation that's harmonized and accessible for research and its application. You can see that's on the left side. To the right are some of the things that we anticipate can be accomplished. To name just a couple, as we're seeing the gratifying translation of research into effective interventions, it's going to be critical that we track the impact of those interventions beyond the clinical trials, identify those individuals who will profit most, those for whom risk is highest, and to identify ultimately a personalized approach to treatment of Alzheimer's-related dementias. In addition, as we have the constant and increasing, if you will, challenge to recruit people into research, an increasing challenge as we find we need to bring people in at pre-symptomatic levels who haven't even encountered the medical system. It's another way to achieve surveillance. And I'd emphasize a couple of aspects: critical that it be done in a secure way with trust, critical that it be pervasive in the whole country geographically and other demographic aspects. So out there for responses and proposals, and we'll see what develops, but we think with a critical kind of attention is conveyed to an integrated real-world data platform as we translate all we're doing into real-world advances. Next, please. This says a lot of what I've been saying. Next. And it just shows you the complexity of necessity for this intervention. These are some of the proposed cores to restructuring what will be a cooperative agreement. Some of them are clear, some are obvious. I alluded to it. I emphasize again a core that will deal with such things as privacy and ethics and populations that have historically been in need of greater reassurance of the security of their data and the fact that the impact will be shared with them. This will serve as an incubator for some of the trials and translations into clinical trials. But a large enterprise were regarded as ambitious but necessary for this next and exciting phase of our translation into real-world applications of our research. Next, please. Another area that received a good bit of attention, including appropriations language, has been exposome research in Alzheimer's. And just to make sure the term is defined the way we all understand that exposome is really the net exposure through life course of any and all external environmental impacts. So this relates to air pollution, to things that are in your food, but also to the social determinants and strategies of health. So all of these important in understanding the risks and mitigatable risks for Alzheimer's disease in particular. So what came with appropriations was a directive for research to identify a coordinating center for this activity. We've made the first of awards in FY22 to rapidly respond with supplements that build the background for what in FY24 will be a number of concepts, including the initiation of the coordinating center, involvement of many of the institutes of NIH, leveraging the great deal of experience and emphasis overall in exposome and exposures, but here we're focused towards its relevance to Alzheimer's and related dementias. Next, please. So Rudy again, the social determinants of health, very high impact. There was a NASM, National Academy workshop last year that dealt with how we can organizationally redesign better to serve the needs of dementia patients. An outcome of this approved concept, that's concept approved by NIH Council, that will be translated, we hope, funding permitted, into initiatives, dementia care coordinating research, consortium for payment, utilization, and access to dementia care. Next, please. Some of the funding and opportunities that have been announced, and here just with the links, but you can see they range through some of our established center programs to an analysis of the an updating of the monetary costs of dementia, and then through an update on the health and retirement study, which is one of our most important population representative areas for longitudinal tracking of cognitive and dementia outcomes. Next, please. Announcements. This is just one example of a new initiative that we found exciting. It's a part of our small business program, and it arises from the observation that really a limited proportion always of those doctoral level graduates in behavioral, medical, social sciences end up in academic careers. An important alternative is their application for the entrepreneurial translation in for-profit business. And for small business opportunities, we're able to do this. So we advertise in FY22 a program for aging-related startup. Had some 200 initial applicants who made their proposals for sort of a mock application for what they might do in the area of aging research, with a large proportion of it relevant to Alzheimer's and related dementias. From this, 20 finalists, each of which will, in the end, will receive a $60,000 prize to move forward with their research. But they receive what otherwise is difficult to acquire entrepreneurial skill training from people been successful in the field. So to increase the diversity of applicants in this program and to leverage the translation in another way, very successful. These are some of the examples you can look at and link to. An impressive group of people, and we'll certainly be reviewing this program. Next, please. The summit in March for care and services. I hope many of you were able to attend in person, remotely. That was the other way, some way. This is a list of some of the major themes, and the presentations are archived and available. It addressed many of the topics we've talked about already today and continue to. And to remind everyone, this reflects our commitment through the summits to bring in national and global level input and perspectives from the researchers, from those living with dementia, from advocacy groups, from those involved in caregiving. This year, in the cycle of 3, was the summit on care and services. As you know, Alzheimer's related dementia research are the other two. So each year we have an advantage of these inputs, which then serve to inform our research program. Next, please. Just want to emphasize the overlay on all of this at NIH is our commitment to structural equity, inclusiveness. Shown here, the Unite initiative, which coordinates a great deal of this. And again, the lead of Unite is Marie Bernard, who for many years was the deputy director at NIH and does an outstanding job. Each of the alphabet letters in Unite is for an important component of it. Understanding stakeholders' experience, new research on health disparities. So research in disparities in Alzheimer's-related dementias, and of course, all of that. Improving culture, structure for equity and excellence in the workforce itself and communication. Next slide, please. And there was the first Unite inaugural progress report, 21-22, for those of you who will take advantage of the link and see what in the initial report and the achievements as well as future plans. Next, please. NIH-wide plan, strategic plan for diversion diversity, equity, inclusion, and accessibility, DEIA, is here as well and outlines the agencies and entire and overall plan in this area. Next. And some updates. NINDS. Thank you, Dr. Hodis, and it's just such a pleasure and an honor to collaborate with the NIA and collaborate with everybody here on these critical issues of AD-ADRD, and just take a few moments today to mention some of the initiatives that the NINDS has that are open right now, and some that will be open in fiscal year 2024, covering this space. And I want to just direct you to, as Dr. Hodis mentioned, links. We have a link on this slide that you can use to search to find these initiatives. Next slide. And I won't be going over these one by one, but just to say that the initiatives cover the full scope of AD-ADRD or ADRD research, actually. The NIDS plays a particular role in the Alzheimer's disease-related dementias. And here you see training initiatives as well as disease mechanisms. And I also want to mention that health equity and diversity is a specific issue that cuts across all of this and is included in initiatives of all types. Next slide, please. I'll actually go back one. There's one I want to call out in particular. PAR 23140 is the fourth line on this slide. I just want to call that out in particular in the context of today's discussions about therapies that have been approved and are in development for Alzheimer's disease and that may be relevant for Alzheimer's disease-related dementias, multiple etiology dementias, which is really a major reality of this space. The NIDS has taken a particular interest and role in understanding the response of the blood-brain barrier to these new therapies, and with the goal of understanding from a mechanistic standpoint what's going on, so that it will be possible to protect people who identify and protect people who are most likely to have a response of the blood-brain barrier to these therapies. And this particular initiative, blood-brain barrier response antibodies targeting amyloid, is one aspect of that approach that the NINDS is taking. Next slide, please. Here we see that there are also clinical trials and translational research, including a funding opportunity announcement on a vascular contribution to cognitive impairment dementia, multiple etiology dementia, and the potential for the current therapies that have been FDA approved in that space. And I just want to point out in the bottom, there's a link that will take you to these funding opportunity announcements, and as well as a barcode. I always say for everybody here and for people that you work with, please, when you receive information from us, please share it. And there's no request for applications. There's no code that is necessary to potentially have access to the AD-ADRD funds that are appropriated to the NIH. We have an extended pay line that we share with the NIA, and that pay line applies if the investigator-initiated research is encouraged and welcome. At the NIS, we also have a listserv. You can email me, or you can go to the webpage and you'll see the name of Taylor Bates there to contact. And a number of you are already on that listserv, but that's a place too where we provide information about activity that's ongoing. So thank you for a few moments to say a few words.
We have questions?
Yeah, thank you. And I actually want to thank our federal partners. I actually was able to share highlights of your January updates with my New England early stage advisory group about a month ago. And many of them were not aware of everything that you do or the services you provide. For example, Aaron, telling them about your National Alzheimer's and just Dementia Research Center, and I'm not knew about that. Or about how you and how you're developing those report against planning guides, which we're all very excited about. I mean, Sherry, I think you talked a little bit about how CMS is making it easier for Medicare beneficiaries to get some behavioral health services with updates to 2023 fee schedule. I mean, those are things that we all could benefit from. And Dr. Hortis, they were thrilled to see your updates on some of the clinical trials going on. And I mentioned your dementia care summit, of which, thanks to your updates, a number of them actually went and participated. So first of all, I want to thank you and show how valuable this is to us. But my question to you guys is, based on my conversation with this group, are we doing everything we can to make sure that those of us living with this disease, are aware of all these great things you're doing? Because my gut says, we're not. I think there can be more that can be done so that even if it's some kind of highlight summary of all these amazing things can get in the hands of the people that need them. And I don't know, should we be talking about, are we doing enough? And if we're not, what do we need to do? That's my question.
I mean, actually, everyone would love to respond. First, thank you for all you've done, and thanks for pointing out that it's not enough. All of us take a lot of time developing opportunities, putting links up, sending them to listservs. But I think a lot of the materials are there. Maybe not everything, but a lot. And the real question is the distribution and outreach and help from all. Alzheimer's Association is a great partner in this, but if the audiences are there, I think many of these materials are there for the sharing and will only improve when we get feedback from the larger audience with whom we share. So it's a fantastic point.
I have a comment, but I'm not letting us respond first. Sherry?
So, Joe, thank you, and thank you to the entire team of advocates, because I think this is a really important point, right? We cannot communicate too much, and but we often don't know. We don't know what we don't know, and in this case, it is enormously true. So we look forward to working with you all, and how do we actually connect the messaging that we have to the audiences who need to receive that information? Often we also, just really acknowledging. We try to put things in plain English, but sometimes when I read it, I go, what? So, I think there's multiple opportunities to actually improve on our communication and throughput of the information. So thank you so much.
So I have some suggestions, but I don't know how much time I have to both of you have questions. I don't want to dominate Q&A. But I do have some suggestions, but please go first and then I'll have you for my thoughts.
Well, I'm most eager to hear your suggestions, but what I'll say is I want to echo Sherry's point that I think hearing that feedback is so important to us because we do really, really strive to make sure that the work that we are doing is known and accessible to the public. And we would love to think about ways to kind of better describe also the whole. So one thing I'm cognizant of is each of our agency partners, NIH, CDC, CMS, ACL, all have in and of their own way a huge volume of activities that they are doing to address Alzheimer's disease related dementias. And a number of those activities actually kind of synergize with each other and help, make the whole greater than the sum of its parts. One of the things that we've really strive to do through ASPE is to try to kind of capture the breadth and the significance of all of the federal investments in ADRD through the annual updates to the national plan. But we recognize that there are opportunities to figure out how we can make that narrative more accessible to different audiences, and also kind of just paint an easier to understand picture of what does all this mean at the end of the day. We have a long list of things we're doing, but what does it mean and how does it translate into benefits for patients, for their family caregivers, for the providers who are trying to take care of them often under-resourced setting. So I think that's something that we would love to kind of think about how to implement, through our annual national plan updates, for example. Another opportunity that I want to give Helen a recognition for in her leadership is last year with the 10th anniversary of the legislation, we planned, we had a 10th anniversary kind of update to try to tell the story of what is it that all of us in this advisory council have been able to achieve and contribute over the past decade of this work? Because in addition to the things that are happening at any given point in time, all of these things have an impact going forward, and have had a cumulative impact over time. So we would love your suggestions and feedback, and we turn it over to you now on how we can kind of better communicate and do that.
So I would look at two perspectives. One is in terms of how to get the communication to that. I look at who you're trying to communicate with. And when you look at people living with the disease, some of them are in support groups because that's how many of us get the help we need. So how are you getting your information down through the nervous system to them? Because I know a handful of support groups that I'm in, I didn't hear about any of these things. So just making sure that you, through your channels that you work with, or even if you're summarizing material, are passing it to them so that they get to be group facilitators to say, here are some things that can help us. Because we didn't have any of those conversations. And if they're not hearing about it, then that's I would say it's a problem, but it's a problem. And then the other thing is how you communicate. One is with somebody living with the disease, you're looking at these issues impacting my life. I would probably say 80% of what we're talking about, maybe 90%, isn't going to impact what's important to my life. But there's 10% that is absolutely really important. Can you somehow summarize this information and say, here's the 10% that really impacts you today? And then here's another 90% of link system stuff that you might find valuable, organized in a way that I can relate to. That if you have time to look at this. But when my head's spinning, I'm trying to figure out how to get my life control. When you give me 100%, I get overwhelmed and I don't get any of it. And then that means none of it's anything. When you give me the stuff that I need to help me figure out how to get my life in control, how to just be grounded because that's spinning. Then all of a sudden you got my attention, and you get in control, and then start looking at the other 90%.
So maybe even in our subcommittees, Joe, and building on what has been said, there's so much information out there. Maybe even the research, the different subcommittees, thinking about what kind of groups we're trying to get information to, and what might be ways. So even if it means packaging it into, from all the different agencies, it's something that's applicable to caregiver support groups or people living in disease support. Like a lot of the different agencies will have newsletters and things that draw attention and different methods to draw attention. Those are for people who are probably working on, a lot in research. So it might be something we can brainstorm in our subcommittee groups. How better ways to communicate all the great work that's being done. So it is a problem even within VA national circles. We talk about these great programs, and other VA researchers wouldn't know what was being done. So even like within agencies, right? That communicate all the great work. So that's what we value the updates.
I think that also goes within advocacy agencies. So I was testifying in Georgia to get more funds for home and community-based services. I used that caregiver infographic from Georgia. I used the Alzheimer's facts and figures on the impact of caregiving. And then they heard it. We got double the amount than what they were going to give us. So just giving it to the advocacy groups too.
Yes.
I just wanted to follow up. Joe's made a very interesting point about how do you enter the system of information that's out there. I mean, I was looking at these slides that were up there. Really, a wonderful informational bits, but they're passing by me very quickly. And I don't have a hard copy, unfortunately, so I can't rely on it. But I'm thinking if the console webpage had a menu listing of the federal agencies and other non-federal partners' websites that provide this kind of information that enters their systems, it would be one place where you could actually go and say, okay, I want to know what Aaron's doing with the AU program. And you click on that and you see all this information, CDC, wonderful graphics, the NIH programs and things like that, Indian Health Service, other organizations that are, spend a lot of time putting their materials on the web. But unless you Google this individually, you don't get to it until you come to a central point. And I'm not sure that we have at this point a central point of access for all this wonderful information as we store it up. Maybe you guys know, but I don't know it.
And then we've talked about that even just having a central point of data collection, a central point, the information changes so much. That it's just going to be a challenge. It's something we can move forward, but
it's a changing thing, but just, the kind of information that you just showed, these in terms of what CDC provides, the wonderful infographics, all the website places to go, and the same thing that I mean, just having that entry point to that page on your website from a common website would be very helpful. And it's not so much that you have to worry about updating data or updating it constantly. It's just knowing where that page is, and as long as that one core page is there for people to access through the central community council room. It would be always available.
And part of that is these slides are available, and I always go back and use them, but they're PDFs that I can't link to the thing. So it puts that other layer of my research.
Email us. Real slide,
Thank you, Mark. Quotas for the real world data platform that's being developed, and you may have mentioned this, because you're going to be across, it's based at NIH, will be across different federal agencies involving other public groups and other different elements and cores. So I assume it'll be like the Alzheimer Center programs and these different other.
No, it will be a cooperative agreement. Meaning it's a grant that is closely managed by a partnership of NIH staff with an awardee. We imagine the applicants will themselves involve consortia of organizations that have healthcare system and access to these various sorts of data. That sort of gets the impression the data will be coming from lots of places. It will be managed in this collaborative way. It will be, by intent, widely accessible. And I should add, although its justification and its emphasis are certainly very focused on Alzheimer's and related dementia, this will be, we envision, applicable to even far broader than that. So we hope that engenders still more enthusiasm and support than this focus.
I'd like to make a comment because as a support group facilitator, as someone who's been in the trenches for 35 years, what I'm seeing is a huge focus on technology, which we absolutely have to do. But we also need to remember that so many people in rural areas don't have access. We're talking that we need to be partnering also with our media groups, whether it be newspapers, whether it be radio stations, television stations, because that may be the only way that they're going to hear our messages. I see it time and time again. And, working with some of these rural areas, and I'll be frank, many of them have different views and how much they feel comfortable with programs from the government. That's just an honest statement. And others are fully on board. But if they don't have access through their media sources, they're not going to know anything exists. So I think that's critical. Then it's kind of on a separate subject, but the wonderful, executive order that's come out and all the data gathering that is going to be initiated to kind of improve systems going down. But I'm wondering, we've had so many closures of adult day health programs and adult day programs over the last several years. Are we going to be learning from them? Why? How did we get to this place where even though we only had marginal, wide programs, now they're diminished. So to accelerate moving forward, are we going to learn from the gaps that they experienced?
If there's 24-hour weather channel, License Care, as you said, License Care radio station or channel 24/7 talking about the information you can find, the latest updates. These are latest updates, sound complicated. You know,
Yes, you see in here.
they can't run it.
They're small and I don't need to alert, but on the disclosure thing, and on the long-term care providers, there is the National Post-Care and Long-Term Care Survey that NCHS runs, and that is going out in the field for its first post-COVID data collection. I don't know if they're doing sort of like a follow-back survey to look at who is not in the sampling frame this time that was last time, but that's an excellent point that you raised. Certainly you can look at who's in there now and how they differ from who was there 2 or 4 years ago. But these are the types of feedback that are really helpful for us to hear as we connect folks in different parts of the government who are doing data collection with some of the policy issues and with the on the ground issues.
Dr. Bierman.
Yeah, I have a question for Lisa. It was great seeing all the work that we're doing, and especially the brain health, and risk reduction work. And I'm wondering, CDC also has Million Hearts that has a big focus on hypertension. And are we aligning like the work on cardiovascular, what's good for the health, the brain, good for the heart? So I'm just curious how you work together with them.
That's an excellent question. And yes, we are working with our colleagues in Division of Heart Disease and Stroke and really trying to emphasize those messages that what's good for your brain is also good for your heart, or what's good for your heart is good for your brain. And at our summit next week, Million Hearts, as well as some of those other programs, will be coming to speak as well too and talk about the alignment. But it's key.
The NINDS is also has been a collaborator on Million Hearts. It's really delightful, it's a great program. And just wanted to mention that the NINDS also has a campaign called Mind Your Risks. Many of you are aware of it already, but I think it's just worth mentioning since it came up that the Mind Your Risk recognizes that a way to protect your health is to control blood pressure. And the Mind Your Risk campaign is a public outreach, and it's in its second phase right now. And in this phase, there's a particular focus on diverse populations and risk for brain health and dementia outcomes in terms of blood pressure control. So I think it's really important points and initiative.
Thank you so much for the federal updates and great questions and things to think about. We'll be breaking for an early lunch, and then we'll be reconvening here at noon Eastern time. So we have about 40 minutes for lunch, which will be up on the floor. So the elevator says PH and house. And then, so for those of you online, we'll be reconvening at 12 Eastern time.
Produced by the U.S. Department of Health and Human Services.